Welcome to this series of interviews with great innovators in cardiothoracic surgery. My name's Joel Danning and we're here at San Diego with Shanda Blackmon. Shanda, you were Chief Division of Thoracic Surgery at the Houston Medical Hospital, and now you're Associate Professor at the Mayo Clinic in Rochester in Minnesota. You've done many things, and you're on the Advisory Council of the American Association of Surgeons, you're on the Board of Directors of the Society of Thoracic Surgeons, and involved with Women in Thoracic Surgery. You've developed a multidisciplinary tumour board and a team approach for diseases of the chest, and you've got an interest in novel technologies such as bronchial navigation, minimally invasive esophagectomy, robotic lobectomy and robotic diaphragm plication. But I particularly like the fact that you're a very modern surgeon and that you have a Twitter feed and you've got an absolutely fabulous video on CTSnet called The Day in the Life of a Surgeon, which has been just almost viral on our website. So thank you very much for coming.
For having me.
Thank you. So the first thing I really want to talk to you about is about how you set up a novel procedure in a hospital. 3 years ago we were actually here in San Diego and you gave a great lecture about how to set up a new program. I was actually in the audience and I was about to set up a VATS lobectomy program, and I did, I hope, everything you told me to do. So I wonder if you could tell me about that, that Harvard Business Review paper and how people should go about setting up a new program.
Well, it's very challenging, especially if you come into a hospital that isn't prepared to start a minimally invasive program. When I came to Houston, they had never had a surgeon that specialized just in thoracic surgery. And most of the surgeons were doing open surgery in my hospital. Most of the nurses were cardiac nurses who were very experienced in cardiac surgery over many years, certainly working with Dr. DeBakey and everyone else. And so trying to teach a whole group of nurses and people that worked with me how to do minimally invasive surgery was certainly a huge challenge. So the first thing that we did was get everyone on the same team. I had a huge dinner at my home. I made everyone feel like they were part of the team. We gave them a scrub top that said thoracic surgery and helped them to identify with our program and not just with cardiac. And we took everyone into the lab and we basically took each nurse, each team through each station: electromagnetic navigational bronchoscopy, how to set up for an endobronchial ultrasound, how to set up for endoscopic ultrasound, how to do complicated EMR procedures. And once we got everyone checked off at every station, we had documentation that we had trained them. We gave them an opportunity to work with the industry people that were teaching the new technology, and then we brought them back into the operating room and we just started practicing. And I think taking every 6-month approach at retraining gave everyone an opportunity to sharpen their skills. And so that was a nice way to do that. The Harvard Business article that you're talking about was called Speeding Up Team Learning. And it's a wonderful, inspirational article because it mirrors when off-pump cardiac surgery started. They looked at 2 different institutions. One surgeon who was a little bit more traditional and very much a captain of the ship and maybe not so receptive to input, versus another surgeon who had a more contemporary team approach and encouraged feedback and was willing to be told, this is a bad approach, we need to fix this, or get feedback from the nurses, where there's more of an even playing field and everyone feels like they have equal input into the development of the program. They buy in a lot quicker. I think the other thing that makes it harder for surgeons to acquire new technology is, especially if you're an older surgeon, you feel very confident, you feel almost as though you're unconsciously competent. You do every step of the procedure without thinking about it. When you learn new technology, you have to go into that state of being either consciously incompetent or maybe even worse, where you're so incompetent, you're not even conscious of how bad, so it's unconsciously incompetent. So we have to learn that technology, get back into that uncomfortable space where you're no longer the expert, and then with your team, learn the new technology and become an expert again.
Yeah, and that Harvard Business Review paper really showed, when they interviewed the staff, the difference. They hated the surgeon doing it themselves, whereas when you brought your team along, they were so much more receptive, weren't they?
Yes, and when you give the members of the team a responsibility, for example, whenever I did an endobronchial ultrasound, My nurse would load the balloon, she would test it, she would make sure our video equipment was working. She had very good parts of the procedure that she did, and she knew that I depended on her for that. And I made sure that she felt the respect and the admiration for all the work that she went through to learn how to do the parts of the procedure that made it a success.
And another part of your way of bringing in a new procedure I really liked was setting up a patient group of all these new vasculobectomies. Yes. So, I mean, tell us about that.
Well, I took on, when I started to build my practice, I took on a patient group that was very risky. It was a group of patients who'd had esophageal disasters. And when I was a resident training in Houston, I recognized that there were so many patients that perhaps didn't have cancer, couldn't get into MD Anderson, but somehow had something horrible go wrong with their esophagus. And there was not really a place for those people to go. So when I was at MD Anderson, I specifically trained to do complex esophageal reconstruction to fill the niche that needed to be filled within my community. And so when I came back and started my practice across the street, I had a valuable tool that no one else in my community really could offer. And I was able to salvage, I think, a lot of patients that otherwise would have had to be, that would have gone to other places or would have had, you know, maybe not an optimal management strategy. And so when I started taking care of those patients, it was a tremendous burden. They're very sick. Sometimes they have esophageal diversion. Sometimes they have a complicated reconstruction. Learning to eat again is a problem. And so I wanted to give them my attention on a monthly basis and help them get through the process. And at the same time, I wanted to learn more about them. I didn't want to just do the surgery and then never see them again. But my resources were quite stretched. I didn't have the time or the availability to meet with each of them on an individual basis, so we started a support group. And that has been one of the best things I've ever done in my entire career. Just meeting with patients the first Tuesday of every month for 1 hour. I found that not only did I learn more about the repercussions of the surgery that I did, I learned a lot about what a difference it was making in their lives. And it helped all of us to heal. If I had a bad outcome, it's very hard for a surgeon to talk about that. But you get the patient through that and you come into a support group, and it's very humbling to sit in that support group and have a patient stand up and say, Dr. Blackmon operated on me, I had a leak, here's how she treated it, I was in the hospital for an extra period of time, but we got through it, and here's how my life is now, and here's what I'm dealing with now. And to have all the people in the room support that patient. So the unintended consequences of that support group was that all of my patients started supporting each other, and I didn't have to be the only sole person supporting them. And so it was a wonderful group, and we stayed so close that even today, like yesterday, I got a text from one of my favorite patients who was 23 years old when I first met him, and he had esophagectomy for esophageal cancer, very young man, and his mom just sent me a picture of me standing next to him at the support group, and he's 5 years out now, and it constantly reminds you why you do this.
Yeah, so it's a support for the surgeon as well.
It's a surgeon support group, that's what it is.
That's great. Yeah. So I suppose turning again to the sort of our modern surgical era, we're in an increasing area of scrutiny. We have our hospital patient reporting, we have outcome reporting, but there's another new era, there's the black box. We're being videoed now, there's vasculobectomy, it's all on telly. Do you think we're going to start an era where we've all got a black box and we review everything?
Yes, well, we actually do. So I think one of my hobbies, I guess you could say, is videotaping every surgery I do. And if you have an event or an emergency that happens in the operating room, there is nothing more valuable to a surgeon than to have that event recorded and to sit among your peers and look back at it like an athlete looks back at a game and say, here's my critical mistake. When I passed the stapler around the pulmonary artery, I accidentally avulsed that small branch. Here's where I recognized the bleeding. Here's where I took measures to put pressure, stopped what I was doing, brought support into the operating room, brought the blood that I needed into the operating room, got an extra anesthesiologist, called in one of my partners, or whatever the circumstance is. It's invaluable to be able to take that black box and sit in a morbidity and mortality conference and look back at what you did right, what you did wrong, and to teach your residents how to be transparent, to teach your residents to be self-critical, to learn. And I think through that process, we actually have less problems. You know, the airline industry does it, the athletes do it, why shouldn't we?
Yeah, but how do you create that culture of being okay to talk about your mistakes? People love to bury the bad news, don't they? It's just a culture?
Except for, I think, among all people in medicine, surgeons are the best. And I think surgeons have a long culture of having a morbidity and a mortality conference. I think the thing that's the critical difference is learning the difference between finger pointing and being accusatory versus creating a climate where you stand up in front of your peers without, you know, you do feel a little bit guilty if you did something wrong, and you do have a little bit of shame if you've committed something that, you know, has a bad patient consequence. But I think it's very therapeutic to do that, and I think it's also invaluable for our residents to see us stand up and say, here's where I made a mistake, and here's how I fixed it, and here's what I'll do in the future different. I think that's how we learn. I think that's important.
So you're on the board of directors of the Society of Thoracic Surgeons. I suppose you know the direction of thoracic surgery in the future, so maybe we can ask a few things about that. I mean, to me it seems that the direction is increased specialisation. I mean, do you think there are too many people generous just having a go to lobectomy? Do you think, you know, we need to tighten that up, or where is the direction going in the US?
Well, I think that's a very good question. I know, especially in Europe, there's much more specialization, particularly with esophagectomy procedures. If you look at the broad spectrum of people performing esophagectomy in the United States, it's quite different from what you see in other areas. I think that the more you do something specific, the better you are at that. And if the very perfect example is the divergence among cardiothoracic surgeons who are now very clearly in most hospitals either practicing cardiac surgery or thoracic surgery. And I think that there are also underserved areas where they will require a more generalist approach to be able to offer treatment, and you might have to have a practitioner who does a little bit of both. I think that the days of a general surgeon going in and doing a gallbladder, a lobectomy, and an aortic valve are probably going away. I don't think you'll see that many more surgeons doing such a wide spectrum of disease. I do think we'll see referral to specialized centers, and I do think with the scrutiny of outcomes, the outcomes are almost always better in a center of excellence. And patients tend to always want to get their treatment right at their front doorstep, right next to home. But I think if they realize by going to a center of excellence and going to a place that does that surgery day in and day out, the same people doing the same thing, that they're getting back into their own home quicker by not getting as many complications. So I think that there's value to that.
And another thing I know you've been very heavily involved in is training and training issues, and there has been big changes, haven't there? The new stream. I mean, how is that going? And has that been well received? And has it been successful?
Well, I think training surgeons who are residents is a very different thing than training people who are out in practice. I think one of the big gaps in our specialty is trying to address the unmet needs of people who are advanced surgeons that are trying to acquire new technology or who are trying to update. There are not a tremendous amount of resources for a surgeon who's been out in practice doing thoracotomies and lobectomies to go in and learn VATS lobectomy without partnering with the valuable input of industry and without finding a way to fund either from their hospital or from their own practice the development of their own practice into a more minimally invasive approach. And it's been great. I've taught probably 300 surgeons how to do VATS lobectomy through our courses, and the more I teach, the more I learn. And I think that there's value, even if you feel like you are good at what you do and you already do minimally invasive surgery. I love going to these courses and learning myself. You always learn new tips. So I hope that the advanced surgeons take the same approach as a resident and continue to learn as they go through their practice.
Yeah, it's a striking thing, isn't it? As soon as you start practice, you stop watching other people, don't you?
Right, you do. And I love going into my partner's room and seeing, you know, how Mark Allen does something, or going into Rob Shen's room and watching him do, you know, inevitably everyone evolves in a different way, and we should continue to learn from one another.
Yeah, so now I wanted to turn a little bit to what I thought was actually a shocking article that you've published recently in the Annals of Thoracic Surgery about women in practice. And it was, I wonder if you could maybe tell us about the results and you know, what we need to do about this.
Well, that was a shocking article. I think a lot of people were surprised that we went to the effort to try to get that information. Obviously, it came from a personal experience. I had twins in the middle of my cardiothoracic residency, and I felt very supported by my program. But one of the things that made me sad was that so many women across the country feel that they have to delay childbearing in order to pursue a career. And I think that that's not always necessary. And I see a lot of women, by delaying the childbearing, putting themselves in an infertility situation where they have to go to extreme measures to have children because they've waited so late. So whenever I have residents on my service that are 35 or older, I very bluntly recommend that they go bank their eggs so that they're, you know, doing what they need to do for their own fertility's sake.
Yeah. I think that paper showed that was on average the women were having children 10 years older than the average population in the US, wasn't it?
Right. In cardiothoracic surgery, the woman on average has fewer children, delays by 10 years having children, and has more complications. And it's a little bit our own fault because we push ourselves physically to an extreme every day. That being said, I have 3 kids now. I just had another baby, and I think women shouldn't not go into cardiothoracic surgery because they want to have a family. That shouldn't be an exclusion. Men never said, I don't want to go into cardiothoracic surgery, I won't be able to have a family. So why should women? I think we just have to get creative on the way that we help women do it. And so I wrote the paper to try to advocate for a fertility policy. That was really all we wanted, was to point out the differences and to encourage program directors to say, this is an unmet need. We have no ability to let a woman go and with some secrecy or confidence and without having to disclose to everyone in their program what they're doing, be able to just take a few days off and go, you know, bank their eggs or do whatever they need to do to preserve their right to have a family.
So, but what, are you advocating banking eggs, or are you advocating better maternity leave, or?
I'm advocating everything that any woman wants to do to have a healthy family. If she wants to have children as a resident, we should support that. If she wants to, and I think it's not a he-she thing. I mean, I think we probably have equal issues with some men who want to have a family and take a few days off to be with their newborn. I mean, how many men have a family in cardiothoracic surgery, and because it's sometimes considered the norm to just come right back to work, I'm sure many men would love a paternity leave, and that's certainly available in most programs, but
I met a female surgeon in Norway, and she just had a child, and I asked about the leave, and she said, well, I took 3 months off, then my husband took 3 months off, right. And they shared it. So I think that's not quite so prevalent in the US and the UK, is it?
Well, I think we're starting to flip everything with regards to how we raise our families. We have a relatively traditional family in my home. My husband stays at home and takes care of the children. I think the more challenging circumstances where you have 2 people that are working, and especially if the resident or the person in cardiothoracic surgery is, whether it's a man or a woman, I think the child rearing is now becoming more equal. No longer does the man go to work and not deal with anything. The men are much more involved.
So finally, I'd probably like to talk about some innovations, because
yes.
I love innovations, so do you. But and you've been here presenting and talking about 3D printing in surgery, and,
yes.
and presumably, I mean, every surgeon could do this. But I mean, tell us about your 3D printing program.
So when I arrived at Mayo, I met a wonderful, inspirational woman named Jane Matsumoto. And Jane is the pioneer that's begun our 3D printing program. Jane and I partnered together and started thinking of ways to use 3D printing to educate our residents, educate our patients, and plan for complicated surgeries. So the first time we used it was for a pan-coast resection to model the tumor in the apex of the chest. We met with the orthopedic surgeon and talked about the fact that the T1 nerve root was involved. We talked about using a novel endoscopic and thoracoscopic approach. We were able to pick our equipment out in advance because we had the ability to measure the length and the ability to test the angles and make sure that we could do a VATS chest wall resection. And then we also were able to plan how we would approach, in a rather unique, novel way, the posterior aspect of the tumor. It also allowed us to educate the patient about what we were going to do. Sitting with the patient with a 3D model is such a better way to talk to your patient about what you're going to do, because you can show them the nerve going right into the tumor, whereas when you show a patient a CAT scan, they're very disoriented. They're not used to looking at a three-dimensional thing in a two-dimensional way. As surgeons, we train our minds to work that way, but patients don't always, they can't pick it up in 15 minutes in a consultation. And then probably every single resident that had anything to do with that case looked at the anatomy and said, oh my gosh, I went through med school, I went through residency, I never understood the anatomy of the brachial plexus and the interrelationship of the subclavian vein, the subclavian artery, and the nerves, and the apex of the chest. And now that I look at it, I immediately understand the thoracic outlet. And it was and they acquired that information, it seems to me, in 1/10 of the time than if they'd sat studying a textbook or studying a picture of a CAT scan or a reconstructed MRI. So I think it's an invaluable resource. The thing that we'll have to measure it against is, obviously, it can be quite expensive. So we have to figure out how to make sure we're carefully printing things that are valuable and not just trying to print everything because we can.
Yeah, well, that sounds absolutely amazing. A great future, isn't it? And,
yes.
And certainly a great future for your patients with a help group and each got a little model of themselves by their side. So, well, it's been an absolutely fantastic insight into hundreds of different subjects, and,
yes.
And I hope you go innovating for many years to come. So from myself, Joel Dunning, and everyone at CTSNet, I'd just like to say thank you very much.
Thank you. Thanks. It's an exciting time to be a cardiothoracic surgeon.
It is, yeah. Thanks.